Hello everyone, it's a pleasure for me to welcome all of you for today's webinar hosted by EUROIMMUN US about the topic of autoimmune encephalitis. My name is Dr. Oliver Senscheid and I'm responsible for scientific affairs here at EUROIMMUN US. And today we have a significant, very high profile speaker to welcome for our webinar. I would like to introduce to you Dr. Maarten Titulaer. He currently is an assistant professor for neurology at the Erasmus University Medical Center in Rotterdam, the Netherlands, and he combines clinical aspects of his work with translational research in the field of autoimmune encephalitis. He holds a medical degree as well as a PhD. He obtained his MD at the Utrecht University in the Netherlands, and he did his PhD studies at the University of Leiden Medical Center in the Netherlands. He spent quite a bit of time abroad doing research, 2 fellowships, one of which was at the University in Pennsylvania and the other one at the University of Barcelona. During that time, he worked with the world-renowned Professor Dr. Dalmau on aspects of anti-NMDA receptor encephalitis, as well as anti-LGA1 or autoimmune encephalitis. In his successful career so far, he has more than 30 peer-reviewed high-impact publications, and I'm more than certain that he's going to continue to significantly contribute to that field of autoimmune encephalitis. And again, very pleased to welcome him here today. And with that, I would like to pass it on to you, Dr. Titulaer. I'm very much looking forward to your presentation today.
Good afternoon. My name is Maarten Titulaer, as introduced. Thank you for the invitation. And I'm hoping to tell you something about autoimmune encephalitis, especially some focus on anti-NMDA receptor encephalitis and some other diseases that might be less known, but also very worthwhile to consider, as you can, as I will try to show you in the next 45 minutes. First, to start with my disclosures, I do receive some research funds for serving at scientific board, some unrestricted research grant, although I will not discuss any medications by any of the companies that are mentioned here. I will discuss some unlabeled use of immunotherapeutic medications. And although there is a huge amount of interest over the last decade for this type of diseases, these diseases are not new, as already in the 60s there were some descriptions of encephalitis in combination with cancers and patients who suffered from lung cancer who had severe neuropsychiatric symptoms, and in autopsy patients were discovered not to suffer from metastasis but from inflammation, and probably these cases were anti-HU, but at that time there were no antibodies present, or we were not able to discover those antibodies. And in the 80s and 90s there were a lot of descriptions of different syndromes that were associated with specific types of antibodies, YO, HU, and those antibodies were all linked to specific types of cancers and specific types of syndromes like cerebellar degeneration for YO, or limbic or autonomic neuropathy for HU. And what all these antibodies, although the antibodies were there, the antibodies were not were not directly causing the disease, because the problem was that there was probably also a very aggressive immune response that was causing damage to the brain and thereby causing damage that was not reversible. So even if the patient was treated well, patients did stabilize or deteriorated further. And that was quite disappointing, and a lot of the initial enthusiasm after discovering the antibodies was gone, and people became a little bit frustrated about this type of diseases. But that's all changed. But before that, I will show you a little bit about why tumors can cause antibodies and why tumors can cause neurological syndromes. And it is
Dr. Titulaer?
Yes?
Thank you so much so far. I've had the response that you're a little soft. Can you speak up just a little bit? The sound quality otherwise is brilliant and crisp, but maybe the volume is a little on the lower end.
Okay, I will try to speak up a little bit closer to the microphone. If you
Perfect,
look
thank you.
if at the upper left side, we can see that a patient who will have a tumor, this tumor can elicit an immune response, and immune response can be both B-cell and T-cell mediated. The B-cell mediated immune response will create the formation of antibodies, and normally antibodies can only survive if they are not body-owned, but if the amount of antibodies that is formed is so overwhelming, this can cause antibodies to be formed that not only attack the tumor, which is a useful effect, but also can attack the body itself, like in the case of neuromuscular junction in myasthenia or Lambert-Eaton, but also if they can pass to the brain, they can attack neurons and thereby have effects. But next to the B-cell response, there might also be a T-cell response, and these T-cells, cytotoxic T-cells, can directly kill tumor cells, which is a useful effect, but as a side effect, they can also kill the cells that contain the same proteins, for example, the proteins we're looking for, like HU of YO, and therefore cause irreversible damage to the brain. But this all changed a little bit, and that was in the last decade, and especially the discovery of NMDA receptor antibodies in 2007 that changed this whole perspective, and that is because in the new antibodies that were discovered all were aimed against an extracellular epitope like a receptor or a synaptic protein, and by direct interaction of the antibodies with the protein, they could exert their effect. So you don't need a real inflammatory response outside of the formation of antibodies to cause the disease. And if we look at those two categories, on the left we have the classical paraneoplastic neurological syndromes that have epitopes that are intracellular, are not directly accessible by the antibodies, and the main effect is by the T cells. Those are the syndromes that do not respond well to treatment. And on the right side, we have all the new antibodies where you have a direct interaction of the antibodies with the epitopes and where you don't need additional inflammatory responses. And if you remove the antibodies by different means we will discuss in the next 40 minutes, we can see that the patient improves again, which makes it very much more important to recognize it early and treat it nicely. So if we look at NMDA receptor encephalitis, I will start with a case of a very typical 17-year-old girl. She was perfectly normal until, while being on a school excursion, started to behave oddly, was very rude, quarreled with her teachers, and became very paranoid. It was progressive in days, and she was starting speaking less and less, and she also complained of headache. She was sent to a GP who thought it might be a first episode of psychosis and sent her to psychiatric evaluation. She was started on antipsychotics, on which she developed extrapyramidal side effects like tremor and some catatonia, and she also then developed, like 7 days later, a tonic-clonic seizure. She had no fever and had a normal CT scan, normal CSF, but was still started on acyclovir to rule out before ruling out HSV encephalitis. The MRI that was done was normal, PCR HSV1 was negative, and EEG was done that was slow, mostly in the temporal region. So we have excluded a viral encephalitis, and we have a subacute onset of some symptoms that could resemble NMDA receptor encephalitis. And why can we say that this might probably be NMDA? If we look at the demographics of NMDA receptor encephalitis in now almost 1,000 patients that have been published, we can see that the median age is 19, that about 1/3 of the patients will be children, that there is a female preponderance, about, especially between 12 and 45, you will have almost 90% of patients that are female, although patients that are under 12 or over 45, it's almost more like 1-on-1. distribution. And what's also important is that about 1/3 of the patients will have a tumor, and this is especially ovarian teratoma, mainly in fertile female patients, although in patients over 45 you might see all other types of tumors like small cell lung cancer or thymoma. Because in a patient of 17 years old you should consider ovarian teratoma. The first symptom that was initially described that about 3/4 of patients were initially sent to psychiatrists, similar to this patient, and this is especially true if you're looking at patients between 18 and 45. If you look at patients under 12, about 1/3 are still starting with behavioral problems, but 1/3 will start with seizures, and also 1/6 will start with movement disorders. So about half of the patient will send to a neurologist first because of seizures or movement disorders, which can be difficult to discriminate in these type of diseases. Adolescents are nicely in between, and in very old patients you will see more memory issues, although still behavioral problems are the most common initial symptom. If you look at the whole disease, about 50 to 60% of patients will start with a prodromal episode of viral, a little bit of fever, some myopathic complaints, some pain, maybe some throat problems, and some fever, and then they become agitated, psychotic, might develop catatonia. Speech reduction is very prominent and might be very well discriminative of NMDA receptor encephalitis, and then they can develop seizures or abnormal movements. Without treatment, or even despite treatment, patients can progress into a comatose state and with central hyperventilation and very severe autonomic symptoms that might lead to even asystole and a need for a temporal pacemaker. What's important, if you start improving, the patient will develop, the symptoms will go away in the exact opposite way. So the last symptoms to come are the first to go, while the last symptoms that remain will be memory issues and behavioral problems. Unfortunately, the improvement part takes much, much longer than the worsening part. Worsening is in days to weeks, while the improvement may take months to even 2 years. What's important, if you look at all symptoms that patients develop within 1 month, you can see that about all patients will develop develop behavioral symptoms of cognitive disruption. Movement disorders or speech are very prominent, especially in younger children, while memory issues and hyperventilation are less prominent in patients that are younger. And also autonomic symptoms seem to be not only less, but also less severe in young children compared to adults. Importantly, aspecific symptoms like cerebellar ataxia or hemiparesis are almost invariably seen in young children, and in adults you should really consider if it's something else than NMDA receptor encephalitis, or that you might have a double syndrome. It's a severe if you look at the previous page, different categories, if we just add them up like cumulatively, we can say the number of major symptoms, and what you can see is that most patients will have 4 or more of these categories that are present within the first month. 3/4 of patients will end up at the ICU, and almost 9 out of 10 patients will be completely dependent on others for their activities of daily living, as resembled by an MRS of 5. What you also can see is that only less than 5% will have 1 or 2 symptoms only, so isolated psychosis or isolated epilepsy. And to know what is, when has been a lot of interest in the amount of patients with schizophrenia or psychosis that will will have NMDA receptor encephalitis and should be treated by immunotherapy instead of antipsychotics. But to look at the literature, it's very important to first know how reliable are our tests. And if we look at this test, this has been done in a large cohort study in Barcelona using research techniques, and we found a sensitivity of 85% and a specificity of 97 to 99%. And this has also been confirmed in other studies from France or Germany. What's important, this is if you only use a cell-based assay. CSF has been very, very sensitive and specific, and what's important is that if you use a non-research assay, the sensitivity of serum even drops a little bit to probably about 70–75%. So use the testing only serum, you might miss important cases, while on the other hand, testing only serum might provide you with false positive or clinically irrelevant results. This is especially important if we look at schizophrenia. For example, all the studies show that it's about 1% of patients with first episode psychosis might suffer from anti-NMDA receptor encephalitis. It's not more, it's not like 10%, it's something like that. It's probably between 0.5 and 3%. And if we do the maths, a positive serum test due to the good but not perfect specificity will lead to a chance of only 50% if you have a positive test that the patient actually has anti-NMDA receptor encephalitis. So to be sure, in patients where you really consider it's NMDA, or if you have a positive test but you're not so sure, you should test CSF. So we get this question like on almost a daily basis. So when should we test NMDA receptor encephalitis antibodies in the psychiatry ward? And I think that's not for every schizophrenia patient, but you might consider to test it for every new onset psychosis patient, especially if it's very subacute, so only a few weeks still there, and especially if there are other symptoms present that could be subtle neurological symptoms like mutism, speaking less, while a normal psychotic patient will speak more. If they have catatonia, if they have fever, tachycardia, hypertension, or bradycardia, and also if they have severe extrapyramidal side effects, even on very low doses of haloperidol. And we don't know, this has been suggested, other autoimmune disease might be a trigger, but I'm not sure whether this is real or whether this is just a selection bias or recall bias by the patients and families. And very important to test a positive serum test in CSF or test by additional testing methods, but that's probably not possible in most normal laboratories. And if you really suspect something, but the serum test is negative, you should test CSF or test CSF initially, like in this patient where we had this HSP testing anyway, so we needed the CSF and we could test it well. What can help us in diagnosing? Not always CSF has to be abnormal. Only 80% of patients will show abnormalities, and these abnormalities are often very aspecific, and so it's not like a typical infectious meningitis or encephalitis where you always will have pleocytosis. MRI will more often be normal than abnormal, and well, in this particular scan it looks like, okay, that's a simple limbic encephalitis, but in most patients the MRI will be almost normal. EEG abnormal in about 9 out of 10 patients, not in everyone, and extreme delta pressures have been described in about 30% of patients, but this was a selected population of very severely affected neurointensive unit patients from Ivy League hospitals. So this is not your typical NMDA patient. So this extreme delta brush pattern you will never see at your regular ward. You will only see it at the ICU in a very severely affected patient. So if we go back to our patient, she fulfilled the criteria for probable anti-NMDA receptor encephalitis as suggested by the Krauss paper in Lancet Neurology 2016. As she fulfilled the criteria, you can see here by the arrows. So we started immunotherapy even before we had the results from the antibody testing to avoid waiting too long before starting treatment. She was started with IVMP and she progressed and needed fixation. Then she was started with IVIG, but still progressed to become mute and somnolent. Then the anti-NMDA receptor antibodies came back positive from our lab, and she was tested for ovarian teratomas, which returned negative. And 2 weeks in, we didn't see any improvement, and we said, well, what should we do? Wait and see, or should we treat additionally? And to know this, we should look at the data that are at hand, and this is a study we did in almost 500 patients, although not for all 24 months of follow-up was available, and we checked by MRS, and 0 to 2 was considered a good outcome because then patients were independent for activities in daily living after 2 years. And if we look at this, 81% of patients had an MRS of 0 to 2 within 2 years. What you can also see is that it can take a very long time before patients achieve that outcome, and patients that were not at the ICU and were treated earlier had the better outcome, which is not so surprising. What's also important, that patients that respond within 2 to 3 weeks starting treatment have a very good outcome, and 97% of those patients will come back to home and will recover very well. But even the patients, and this is about the other half of patients that do not respond within the first 2-3 weeks after immunotherapy, we looked into those, like, okay, what has been done in those patients? Some were treated again by steroids, or treated again by IVIG, or were switched from IVIG to plasma exchange, or the other way around. And in those patients, we found out that even those which were on average on the ICU for already over a month still responded quite well, and 55% of those patients were back at home after 2 years. But if we look at the patients that were treated with rituximab or cyclophosphamide somewhere in the 2 years after onset, in those patients, over 75% of the patients returned back home. Of course, you should be very careful with these results, as this is a cohort study and it's not a randomized trial. And of course, there might be some selection, although we couldn't identify some. But it seems like the addition of second-line immunotherapy is useful in those patients. And if you would calculate an odds ratio, 2.7, although that's officially not allowed in a non-trial fashion. And it's not so illogical to consider that patients might not respond to IVIG or plasma exchange, as it was discovered in this unfortunate woman that died due to NMDA receptor encephalitis and was tested in the Philadelphia lab, that patients have, and this is important, especially the CD138, which is a marker for plasma cells, a plasmablast, that patients have plasma cells in their meninges and in the parenchyma, and therefore can form thousands of antibodies every second in the brain itself. So it doesn't matter whether you clean the blood by plasma exchange or by IVIG, if you still remain creating antibodies in the brain itself. And therefore, more aggressive treatment might be useful. So our current treatment flowchart is that we start with MP and IVIG, wait 2 weeks whether there is an effect. If there is an effect, yes, then we watch and wait, and after 4 and 8 weeks, we repeat treatment to avoid a recurrence of the disease due to the antibodies not all being gone within the first 4 weeks. If they don't improve, then we don't wait for too many weeks before starting more aggressive treatment. If they're young, if they're old patients, then we start with rituximab and cyclophosphamide, although currently we might be a little bit more reluctant for patients between 16 and something like 30 to directly treat with cyclophosphamide as well. And then we see whether there's complete B-cell depletion, so showing that the rituximab does their work. Then we continue cyclophosphamide, and if there's not complete B-cell depletion, we also add another round of rituximab and continue with cyclophosphamide. In younger children, we start with rituximab and only treat with cyclophosphamide if necessary after rituximab treatment. Of course, this is just an expert opinion and not a trial-based flowchart. So if we continue with our girl, just before we wanted to start with rituximab, she started improving and said, okay, well, we can wait a little bit more. And we gave her IV-MP after 4 and 8 weeks, and she recovered over, well, about 9 months. She completely recovered. And I spoke to her a few weeks ago, and she's doing great and doing her internships and doing very, very well since. 8 months later, an ovarian teratoma was identified that was initially not visible And we discussed with her, okay, if we do not remove it, we don't know what happens. It might be that you never have a recurrence, or we can remove it electively, and then you will be sure that you will have never have a relapse. She chose to have it removed, and that went without any complications. So there's a lot of course, before starting to treat, you should exclude other diagnoses, and especially HSP1 encephalitis. If you really consider diagnosis, you might be able, using the criteria from Lancet Neurology, to start treatment early. You should avoid haloperidol because of risk not only of extrapyramidal side effects, but also reported risk of malignant neuroleptic syndrome. We always provide pulse steroids instead of oral steroids, taper to diminish the behavioral effects while being in rehab. And it's important to screen again, because we know from all of the paraneoplastic neurological syndromes that about 1 out of 6 patients that ultimately will have a tumor has a initial clean screen, and the tumor is only found later on. Although still the majority of patients will never develop a tumor, it's important to screen again. How frequently patients do relapse? It's about 12% within 2 years. What's important is that patients with a tumor might have more chance of relapse until the tumor has been removed. And what's also important is that most relapses are milder, and that you can treat them earlier, probably also because of quicker recognition, quicker treatment, thereby avoiding the full-blown severe clinical picture. And you should consider to have another screen. And what's also important is that patients that have one relapse have 30% chance of a second relapse. And therefore, and as we could show that also patients with second-line immunotherapy have lower chances of having a relapse, we suggest to wait and see, not treat all patients with chronic immunosuppression, but if they're instructed well, you can treat them very early. And of course, if you already treated them with second-line immunotherapy, the chances are very, very low of having new relapses. And also, if patients do relapse, we tend to treat them with second-line immunotherapy to avoid new relapses. And with that, I would like to switch to a little bit to another disease, although it's quite the same. This was a very young girl, 2 years old, that developed HSP encephalitis with dysphagia and also spastic paraparesis. She was recovering a little bit and then developed this choreatitosis and also lowered level of consciousness. And she was treated with steroids and IVIG, but they didn't know what it exactly was, and she didn't improve. One of my colleagues, Thais Amangue, who was the author of this paper, she by accident came by this patient and said, well, this resembles NMDA, and tested her for NMDA and turned to be positive. This was the first patient that was discovered with post-HSP encephalitis, anti-NMDA receptor encephalitis. She was treated with rituximab, and this is the same girl after the second infusion of rituximab. And you can see that she still has a paraparesis, a spastic paraparesis, and also she still has a tube to feed her, but she has improved since, and this is even before she fully recovered. Unfortunately, she still has the deficiencies due to her HSP encephalitis. This was not the only patient. Later on, this was a young male patient of 23 who developed behavioral complaints, and we were able to show that the patient initially had no NMDA antibodies during her HSP episode, and 1 month later she had NMDA receptor encephalitis antibodies while she didn't have a positive PCR for HSP anymore. And a prospective study from Spain showed that up to 25% of patients with HSP encephalitis will develop a secondary NMDA receptor encephalitis. This might show as a new amount of symptoms, but might also show as just a stagnation of the initial recovery. So we should see these patients and we should test these patients, because if you treat them with immunotherapy, they start improving again. So with that, I would like to remove from the anti-NMDA receptor encephalitis and show you this 63-year-old woman. And please look at her arm and head. She's an EEG monitoring, and there, that's what you can see on the right arm and on the right mouth. And afterwards, she's a little bit distracted. You can show it here again. That's it. Just a few seconds, and she had this for 100 times a day. And if you see this, this is called facial-brachial dystonic seizures, although there's some controversy whether the patients actually have seizures or that's a movement disorder, but this is pathognomonic for LGI1 encephalitis. LGI1 encephalitis was only discovered in 2010 and was previously known as VGKC encephalitis, which was linked in the 90s to neuromyotonia and Morvan syndrome. And research from Oxford and later also Philadelphia showed that patients do not have VGKC antibodies, but actually have antibodies to LGI1 or to Caspr2, which are two separate proteins and have separate clinical phenotypes. So if we look at LGI1, it's a synaptic protein that's linking the presynaptic potassium channel, so it is linked to the VGKC complex, and the postsynaptic AMPA receptor via the Adams proteins. Patients with human mutations, they have autosomal dominant lateral temporal lobe epilepsy, and mice without any LGI1 have a very severe form of epilepsy and die within weeks. So it's very likely that these patients with antibodies would also have epilepsy. And that's also what we see. Anti-LGI1 encephalitis is a disease a little bit more affecting males. Average age is 60. And what we can see is that it is typically a limbic encephalitis with seizures, but also memory problems, behavioral problems, and insomnia. And they will only develop a tonic-clonic seizure late into disease, and that often leads to a more profound diagnostic process. And what's very important is that MRI can be abnormal, but doesn't have to be abnormal. CSF is in 3/4 of patients normal, and most patients will have no tumor. 2 out of 3 patients will have a mild hyponatremia. And if you start treating them, the seizures go very quickly, but the cognitive symptoms can remain and can subside in months or not at all. What's also important is that about 10% of patients will only have a limbic encephalitis, but without the seizures. So they have behavioral problems, they have cognitive symptoms, but no seizures at all. These are very difficult to discriminate. MRI, as I said, can be abnormal, and it can show this very specific T1, T2 hyperintense basal ganglia abnormalities, but this is very rare, only in about 5% of patients. More frequently is more aspecific with some unilateral, sometimes bilateral T2 flare hyperintensities. And those are the patients that might develop atrophy and mesial temporal sclerosis. All patients will be VGKC positive, but what's important is that serum, especially using the widely available assays, is more sensitive in serum than it is in CSF. So for NMDA it's the opposite, but in here it's important to test serum. And that's with all the antibodies, some might be more sensitive in serum, the others in CSF, and therefore it might be useful to send in at least both and then determine which one you want to test for which one. What's important is the seizures, because if you treat the seizures early, recognize them, you can prevent the cognitive problems. So there's 3 types of seizures. You have the facial-brachial dystonic seizures that are pathognomonic for LGI1 encephalitis. They occur very frequent a day, median of 40 a day, are very short-living, and will not show abnormalities on EEG, at least not a regular EEG. What's important is that most of these seizures start before the cognitive symptoms. So ideally, you could start treating them before they develop the cognitive problems, which are much more refractory to treatment. The second type of seizures are focal seizures that are non-FPDS, take a little bit longer, are detectable in EEG, and are very, very stereotypical. People might complain about goosebumps, they might complain about a specific feeling that, or gastric rising, or absence-like symptoms, and also these symptoms, all these seizures also start before cognitive problems and might be a way to start treating before the cognitive symptoms start. The third is the most well-known, the tonic-clonic seizure, very infrequent, and are late in disease. So if patients have a tonic-clonic seizure, you often are already in a month, some months of disease, and you might want to treat them earlier. And this is proof from Oxford, from Irani, from Brain, where they show that patients that are started on immunotherapy, they do very well on immunotherapy, but do not respond to anti-epileptic drugs only, and that starting early might prevent cognitive symptoms. And if you look at the outcome, only a quarter of patients will recover completely, and a large majority of patients will be left with mild to sometimes very severe cognitive problems that might resemble more like a Korsakoff syndrome. So the unfortunate thing is that although they do respond very well to immunotherapy seizure-wise, they will go in days, sometimes weeks. The cognitive symptoms might be more severe, and in the end, the outcome is worse than in our NMDA receptor encephalitis patients who end up on the ICU in the acute phase much more frequently. Relapse rate, different options are there. It's between 5, and the last studies showed 30 to 35% of relapses, also in our own cohort. And we've started treating them with chronic immunosuppression, and thereby, at least in the first 2-3 years, it seems to reduce the amount of relapses considerably, comparable to the 5 to 10% that was published by the English, who already started using chronic immunosuppression early on. So for that reason, at least I would like to, you should consider it and discuss it with the patient, whether you should start chronic immunotherapy, I think. Within the PGKC complex group, we have the LGR1, and secondly, we have the Caspr2 antibodies. Caspr2 is also a limbic encephalitis, but patients might have Morvan syndrome, which is a combination of limbic encephalitis, peripheral nerve symptoms, and also some autonomic symptoms and insomnia. And what's important, if we look at Caspr2, patients might have tumors, mostly thymoma or small cell lung cancer, about 1 out of 5 patients. And if we look at the symptoms, Caspr2 is a protein that's present both in the peripheral and in the central nervous system. And the symptoms we can see are actually in the whole nervous system, because the protein is present everywhere. So patients can have cognitive symptoms, can have epilepsy, can have cerebellisms, can have pain, can have weight loss, can have peripheral nerve hyperexcitability, autonomic symptoms with severe hydrosis. So actually you can have everything, which makes it a difficult disease to consider. And every patient seems to have its own combination of symptoms. And then we have the third group of patients that are PGKC positive by the test, but are LGR1 and Caspr2 negative. And this amount has increased over the years that started to become testing PGKC positive, but was tested negative for LGR1 and Caspr2. And we do not actually know what's in there. So we looked at these patients that were LGR1 Caspr2 negative, but PGKC test positive by 2 independent researchers. All patients blinded for PGKC therapy or outcome, and what we found is that there was no difference between the chance between patients that were PGK positive or PGKC negative with the same clinical phenotype. There was no difference whether they were autoimmune or not. So apparently, PGKC tests themselves has no additional value. Also, it's not useful to look at the titer, because if you take a low cutoff, you would overtreat a lot of patients that do not have actually any autoimmune disease, while if you take a high cutoff, you will miss a lot of patients that should profit from your treatment. So it seems that it's not very useful to use the PGKC test by itself, and a study from the English group recently confirmed this, although they did find some patients who have intracellular antibodies against intracellular epitopes of the PGKC channel, but this was irrelevant to the clinical phenotype, and irrelevant to treatment response. What is important is the clinical phenotype, because our patients that had a limbic encephalitis and it had with or without VHKC test positivity had a higher chance of having a autoimmune disease, while patients with epilepsy or psychosis had hardly any chance of having an autoimmune cause, irrespective of the VHKC result. So it's important to look at the clinical phenotype, and to help you with the clinical approach, it's useful to look at this paper that position paper I already mentioned before. And this has a whole flow chart how to look at these patients, including even probable seronegative autoimmune encephalitis. The last disease I would like to discuss is this 57-year-old male who suffered from diarrhea and weight loss very severely after a visit to Egypt, and it was considered to be diarrhea due to an infection, and a blastocystis hominis was discovered and treated. But still he was deteriorated, the diarrhea remained, but also he had social problems, divorced, was discharged as a lawyer, and he became a regular client to psychiatric wards. He also showed some short-term memory problems, and neuropsychological evaluation showed that he was very, very slow, and then he developed some rigidity and myoclonus, itching, and was sent to a neurology department to have a second look at it. MRI was done, which showed some big bitemporal atrophy, but rather aspecific, some slight slowing at EEG, and a CSF lumbar puncture showed a little pleocytosis, little high protein, and matching oligoclonal bands. If we consider this, it was very slowly progressive, which is normally not considered to be compatible with encephalitis, but for autoimmune diseases, some of them can be rather slow, and DPPX or CASPR2 are two of them. Weight loss and diarrhea for the gastrointestinal symptoms could be linked to DPPX or HU, and the rigidity and the myoclonus, the hyperexplexia, and the startle response could be linked to DPPX or glycine receptor. This patient also had very severe itching and therefore could not wear clothes, which was very prominent in this specific case. He turned out to have DPPX antibodies. If we look at DPPX encephalitis, it's a limbic encephalitis or sometimes a brainstem encephalitis, mostly a little bit more males. Most patients are over 40, and some patients will show pleocytosis, but not all. MRI is rather non-specific, and 5 to 10% of patients will have a lymphoma. Very importantly, patients will have severe weight loss and diarrhea in a considerable amount of patients, and that's due to the fact that DPPX proteins are also in the myenteric plexus, and therefore the diarrhea is a direct effect of the antibodies acting with the DPPX and not a prodromal effect, for example, in Guillain-Barré syndrome. Patients can have myoclonus and startle as well. And if we look at our patient, he was treated with steroids, IVIG, and plasma exchange, which all had transient but short-lived improvement and then deteriorated again. So in the end, as it was a very inconvenient situation, we started on rituximab with cyclophosphamide, and he responded very well, but then relapsed again, and we treated again with rituximab. He had a bone marrow function already initially, but that was considered normal, but we revised it after the relapse, after the initial rituximab improvement, and it showed to have a hematological malignancy, and it has been treated for it ever since and doing very, very well. So what's important is that you should always consider, if the patient is not improving or relapsing, that it might be a paraneoplastic origin, but also in this specific case, although the DPPX antibodies still respond with the gastrointestinal tract, often, and this has been published in much more patients, that the gastrointestinal symptoms are there only initially and can resolve and not recur later on in disease. So I had no time to discuss all the antibodies, but what's one last thing is the GABA receptor antibodies, GABA A or GABA B, which show with a very prominent seizures, status epilepticus in combination with limbic encephalitis, and can be cured by immunotherapy as well. And I would like to refer you to the papers down there to look the specific symptoms. And take-home message, it's important to recognize, because the diseases are treatable, the disease occurs at all ages, but the encephalitis can be less specific, more resembling encephalopathy. So it's important to know the clinical phenotype, know the tumor associations, to treat them as best as you can and as early as you can. It's important to know the pitfalls in diagnosis, especially in serum. You should consider combining serum and CSF, especially if there is atypical phenotypes, and probably the PGKC test should not be used by itself, but you should start using LGR1 and Caspar-2 testing. It's important to recognize, because treatment is rewarding, although it can be difficult and you can have to be very patient, but in the end, aggressive treatment is useful and the outcomes may be very, very rewarding for both patients, families, and physicians, because most patients will have a good outcome. And with that, I'm thanking all the people that has done all the research, and specifically Joseph Dalmau has been my mentor in this field for the last years. I would like to thank you for your attention.
Perfect. Thank you so very, very much, Dr. Titulaer, for this very exciting and insightful presentation, talking not only about the antibodies, but also how they affect and how they can be treated. With that, I would like to thank the audience, and I would like to open it up for discussions. If there is any question you would like to address and want to ask Dr. Titulaer about what he's just talked about, this is the time and place now to do so. Please use the chat functionality on the left bottom corner to post your questions. Before we have the first questions coming in, I think I would like to kick it off with one aspect that really struck me when I heard about it for the very first time. That is the idea that potentially some of the patients at psychiatric wards are suffering from, for instance, autoimmune encephalitis by means of anti-NMDA receptor antibodies. Has there ever been an estimate of how many patients could potentially be affected in that way, instead of just suffering from other diseases and then just being treated for their symptoms?
Well, there has been at least cohort studies that showed both in schizophrenia and in first episode psychosis. And in schizophrenia, there have only been patients that were identified that, if you look carefully back, had a much more outspoken disease, much more than only psychiatric symptoms. So we shouldn't be too worried that there are patients that are suffering from an active schizophrenia hidden somewhere at psychiatric wards that are actually having a treatable disease. I think it's the difference between psychosis, first episode psychosis, and schizophrenia. In first episode psychosis, yes, it can occur. It probably is still rare, and best estimates are that it's between 0.5 and 3% of patients with first episode psychosis that they can have anti-NMDA receptor encephalitis or anti-AMPA receptor encephalitis. AMPA receptor encephalitis is much rarer than NMDA, and occurs at older ages, but the clinical phenotype might completely resemble NMDA receptor encephalitis. And we've recently seen a few patients from psychiatric wards that initially purely had psychiatric symptoms they were not distinguishable very well between regular first episode psychosis and atypical ones. But most of them, almost all of them, will develop some neurological or some systemic symptoms within the first weeks. Fever, bradycardia, seizures, mutism, hypoventilation, and so most of them you will be able to discriminate. But we have 1 or 2 cases, so very rarely, that they will only have psychosis beyond 4 weeks into disease. So yeah, it is, of course, there is some problems that not in all of the patients CSF was tested. So there might have been 1 or 2 patients that have been missed in the past due to that, but I don't think that there will be large numbers, but we do consider it if asked for by the psychiatrist, and also regularly. If there's any doubt, we'll do a CSF.
Perfect. Thank you very much for this. We have 2 questions. The first one of which I can address directly. There was the question to what degree the information will be made available after this webinar, and yeah, we will share a video of this webinar after this presentation, so I can put your mind at ease. The other question was related to the question whether there has been other associations with herpes virus encephalitis and NMDA receptor encephalitis, for example, VZV.
There has been 1 case of VZV, 1 of EBV, but to be those cases were not very clear cut. I don't think that for HSV there is clear evidence from multiple centers using all the techniques that are possible that there's a clear combination and it's a frequent co-occurrence of always NMDA 3 to 6 weeks after the HSV. For all the other herpetiform viruses, it might make sense that it does occur, but the current evidence of the cases that are published is not so well documented, at least not in my opinion, that it's a clear-cut association as well. I would say HSV 1, yes. All the others might be, but currently just a theoretical suggestion and not proven.
Okay. Thank you very much. It appears we have another question coming in. I was wondering if there are any rational suspicion on why serum testing for LGI1 is more sensitive compared to CSF testing.
There is, well, for one thing, we know for NMDA, for which CSF testing is more sensitive, we know that most patients will have intrathecal antibody synthesis. If we look at LGI1, we can see that the titers absolutely, but also relatively, are higher in serum than in CSF. So we do know that at least we consider that normally the inflammation starts in the system and then might move to the intrathecal compartment. For example, for NMDA, and then you can have oligoclonal bands, things like that. For LGI1, probably the inflammation and the trigger, but also the continuation of the systemic infection remains from the system, and therefore, as the antibodies are much more prominent in the systemic circulation, the noise, the signal to noise ratio is better in serum than in CSF. That's one reason. The other reason is we don't know is that with additional testing by immunohistochemistry, we can see that in most of the patients we can identify the LGI1 antibody, we can see the specific staining, but for some reason we cannot test it in the cell-based assay, and this might have to do with the fact that the LGI1, which is a synaptic protein by itself, to use it in a test system, it has to be linked to the membrane, because otherwise it would be washed off during your washing steps. And it might be that the 3D conformation changes a little bit, and if patients have lower amounts of antibodies, that this is more critical than if you have higher numbers as in serum, and that therefore the cell-based assay becomes less sensitive than the immunohistochemistry technique. But this is purely speculation, but it might be one of the reasons. But probably the most important is the decide where the most antibodies are formed. For NMDA, it's in the intrathecal compartment, so therefore CSF is more reliable. In LJ1, it is in the serum, in the systemic system, and therefore it's more reliable, similar to, for example, ApoE4.
Perfect. Thank you so very much for these insights and the questions to your answers. And yeah, there's also big thanks from the person who asked that very question. With that, I would like to use the last 2 minutes to briefly discuss upcoming educational events and very briefly the portfolio of EUROIMMUN. So EUROIMMUN is a market leader in autoimmunity and hence also market leader in the field of autoimmune neurology, has by far the most comprehensive portfolio, and all of those parameters that Dr. Titulaer mentioned in his presentation will be covered by test systems by EUROIMMUN, both for serum and CSF, and as per the guidelines with a combination of tissues to screen for, as well as monospecific confirmatory testing. So we have a strong portfolio in paraneoplastic syndrome testing with all those established markers that have been around for a while, but also on the other hand, the markers associated with, sorry, slides are somewhat laggy, markers associated with autoimmune encephalitis, which is the NMDA receptor, the AMPA receptor, GABA, etc. So entire portfolio covered in those disease states, as well as in disease states like neuromyelitis optica, spectrum diseases. Aquaporin 4 is a very prominent marker, but MOC has also picked up some steam recently and is requested very much so. And autoimmune neuropathies, manifestations of the peripheral neural system, including MAC antibodies and antibodies against gangliosides, can also be tested with EUROIMMUN products. At the same time, a lab in these days is challenged by the need of automation. So all our IFA product, indirect immune fluorescence product, can be fully automated and processed by either our Sprinter XL or EUROLab workstation, which does the incubation and the dilution of samples, and these slides can be fully automatically be imaged with our EUROPattern microscope, which eliminates the need for darkroom time and also sorts all the data per person, dilution, and specific parameters. At the same time, monospecific testing by means of our line blots, the EUROLINE assays can be fully automated with our EUROBlot 1. And both solutions can be bidirectionally linked via our EUROLab office to your laboratory information system, which allows you to assist you with sample management, generation of protocols, preparation of the final reports, and most of all also the archiving of data, which as we learned, very important for those patients with encephalitis because they will have follow-up samples. If you're interested in any of the assays or automation solutions, please send an email to sales@EUROIMMUN.US. So overall, EUROIMMUN presents itself as a scientific leader in the field of autoimmunity, including the field of autoimmune neurology. We have the most comprehensive portfolio, characterized by numerous exclusive IPs, either by patents that we own, but also through exclusive licenses that originate from strong scientific collaborations, which leads to a very rich and strong pipeline of EUROIMMUN, and we are going to continue our R&D efforts to that end, for instance, with projects in which we aim to identify unknown fluorescence pattern and identify monospecific targets, hence identifying new autoantibodies in the disease states. Last but not least, I would like to draw your attention to some of the upcoming educational events of 2017 and 18. So thank you, Dr. Titulaer, for the first of 2 expert webinars on autoimmune neurology. Dr. Ramona Höfberger is going to speak about other aspects of autoimmune neurology, including paraneoplastic syndromes, on November 4th of this year. Each and every one of you signed up for this event will receive information in due time for this event. For those of you from the United States, There's going to be a luncheon seminar during this year's AMLI at August 15th, during which Dr. Stanley Nates, head of the immunology at Quest, San Juan Capistrano, is going to talk about laboratory testing aspects of neurology. And last but not least, please stay tuned for a special event that we are currently planning to host during next year's AAN, American Association for Neurology annual meeting in Los Angeles. If you have any question to those events, please reach out to us. You will also receive information prior to those events. And if you happen to be at one of the following shows, SCASM, ACC, AMLI, ACR, or AMP, please feel free to swing by our booth, EUROIMMUN US, and learn more about our products and our solutions we have to offer. With that, I would like to conclude today's webinar with a big thank you to both Dr. Titulaer for this outstanding and excellent talk, and to our audience for taking their time out of their busy schedules. And if there's any questions afterwards, please feel free to follow up with us. I say a big thank you to all of you, wish you a great day, and hope to see all of you back for some of the upcoming educational events hosted by EUROIMMUN US. Thank you so very much. Have a great day.